set to join. So I think you may be in now dilemma what to study. Yes. So everyone will be happy, and more and more, same time you may be having some like how to go with this mains, how the question paper will be there. Yes. So your voice is audible only. Yes, I'm voice is audible. Yes, voice is audible, right?
Sir, voice is audible, clear, sir. No.
No, no, no. Okay, fine. Yeah. So those who have cleared this prelims, I think you are have a good position because 8,000 people only they have selected, right? So there is no much difference between you and top ranker. Like everyone have the difference between 4 or 5 questions only. So you are all eligible candidate. Only thing the competitive the mains which are going to which is going to held on 5th of May. So how you are going to prepare? So we give some tips. So there is nothing special like what I said. You'll be getting the same and some of the thing which we updated because we have seen the questions and the question paper is very easy actually. If you see only thing people those who are not in the clinical side, so they may have some issues. Okay, but the remaining question papers are easy and 37 questions from our test series we marked and kept the answer. 37 questions from Karthik sir question papers we who discussed it. He given the this one. And apart from that, directly from my slides. And your 65 questions easily you can write if you attend the session for last 6 months. So same thing which we plan and we can execute in the main. So we work something different way in the coming 14 days, how we can work. Okay. So especially for this, our batch students, maybe some outsiders or Metier students, both are there. I think so. Yeah. So anyway, let me explain the schedule which we are planning. Okay. Yes. This time, how you are going to prepare, I will tell. So let us plan accordingly. So you are well versed in the content. Already you studied the content for last 6 months. Okay. So you have to study the content. Little quick review of content. Okay. So yes, little quick review of the content and what I plan to execute this coming 14 days. So we go with this 12 days of live quick revision, which probable topic. Once again, let us see the question paper of this. We have seen the question paper of the prelims. So let us have some prediction and go with the most probable topics with content revision. So which is going to be held at 3 to 9 p.m. Okay, purely online. And I added the scenario questions. Generally, daily, I was about to think 30 to 50 questions. Morning 6:30 to 7:30. Okay. So I'll be discussing with this morning 6:30 to 7:30. Only the scenario MCQs, which as per our predictions, we can discuss combined together. So, and the test series, 10 test series, you know that there is no aptitude reasoning. Okay. So, you people should know aptitude reasoning was not there. So, there is a question of same 100 marks, same pattern. So, all of one nursing syllabus. So, it will be easy for you. Only thing you have to recall whatever you studied for this. I think those who have the confidence the last 3-4 days, you may complete the content revision very fast. Okay, the result maybe waited, but those who are having confidence they may complete the content revision. But still, 10 test series with as per mains pattern. So we are working for new test series. Let us see how it will work. And then one grand mock test as per the new pattern, which is on the 13th of the 4th of this May. Okay. Then this is the pattern which we plan. 12 days of live content revision, which starts from tomorrow, 3 p.m. to 9 p.m. And if you see the magic pill session, which I added extra for questions, I will be discussing all the magic pill session as per the topics which we. So app validity will be getting for new students up to May, and mode is completely online. Okay. I think all are old students only. I think so. There is no new student. I think. If a new students is there, please let me know. Okay. So what we do here, we have a quick this MCQ which I said, MCQ scenario based questions only we are going to focus in this 10. Okay. Okay, new students are there is well and good. So okay, this is my profile. So I may introduce myself for the new students. Okay. So yeah. So I'll be dealing with all the questions pattern MCQs except specialty, which OBG, psychiatric, PEDS, and this one research management. So remaining all funda, critical care, MCQs, all will be studying with me next 10, 12 days, every day morning and evening session. Okay. So along with you, will be also preparing the core content which we need for the exam. Okay. So just a minute. Gokul, I think this PDF is attached with the other program.
Sir?
I think this PDF is attached with this one. Acha. Okay. This is the syllabus we framed, right? Okay. You can see this one.
Sir, this is the PDF, sir.
This one.
Yes, sir. Yes, sir. Oh, that only. Okay.
Okay. So the syllabus which we are going to cover, I given the schedule. Today is 25th and demo, which we had now. I'm going to discuss some of the new session. And tomorrow morning, no session. Evening 3 to 9, we start with funda, which clinical aspects, clinical skills. Funda means purely the clinical skills, because you see the question paper, basic questions are there. People are lacking the basics. Let us study the basics as well as quick review of the important topics. And every day morning 6:30 to 7:30 sessions for MCQs, generally not subject wise. So because already you people have studied your prelims and cracked, so better we can have quick revision, the pattern of scenarios. Okay. And also basics. So like that, we have the given the syllabus. Wednesday we have psychiatric and daily test series 1 and test series 2 will be started from 21, 22. 22 it is started. So you can practice the test series also. So this is the pattern which I followed, and we see coming with some of the updated clinical aspects apart from new content. Like old contents were there, 80% old content. If you change all the content, students will get confused. Okay, better we have the same content, but along with that, some new updated clinical guidelines. We also working for that. Okay. So this is a pattern. See, timing 6:30 every day morning till 2nd we have the session. Okay, so 2nd we have the session, and as well as last session is your community research management. 10 test series will be there, and one grand mock test will be there. You will be free from 3rd and 4th. You have the self revision mode, and you can start practicing the self revision. Okay. So perfectly we plan the schedule, which because you all qualified already prelims, so we are happy to invite you for the mains, and we are very happy, and surely you may all get a good rank in the upcoming mains exam. Okay. So when you have good schedule and proper planning, so schedule we have fixed only compared to last time we came with only limited fees. So all students and new students, there is a fee structure you can see. Okay, if you have any doubt, you can go with this number or this one to get a all students link. Okay. So for how to join, you have the PDF which is circulated in the group. You can go and check this, click the PDF and go enroll through the online. Okay. Last date of enrollment is 25th. Okay. So remaining of any doubt you can ask, no problem. So let us have the pattern. You all know that there is no aptitude reasoning. Nursing only, no aptitude reasoning. Okay. That is good news for you. Okay. So that is good news for you. There is no aptitude reasoning. Okay. So test series we are not going to discuss. Okay, because it's waste of time. You can do that because you are a little mature now. You cracked your exam, so you are going to go for self revision. Okay. So we'll see when we can upload the session in the morning time. We'll inform you today. Okay. So every day, maybe before day will be tomorrow evening we'll be releasing one session maybe. So one by one daily will be releasing, so you can have the revision, quick revision. So don't worry about GK. There is no GK aptitude. In the language solno, kaun sa language mein bolna to you can tell. There is no aptitude reasoning GK, which is given in the schedule clearly. Okay. You can see that there is no 100 marks from the 4 alternative each questions related to subject covering entire syllabus of nursing courses being taught at the essential qualification level focused towards case-based scenarios question for testing nursing skill competency. This is what given in the mains website. Okay, AIIMS website. No, it won't be useful for the ESA exam. Okay, ESA will be having separate crash course. Those who are writing only NORCET, you have to upload your all ticket and you have to join the class. We don't entertain other people. Those are studying you. Clearly, I'm giving the instruction. This is only for NORCET. Okay, it is not working out for the ESA, and moreover, ESA you have more 3 months more time. Okay, there's no point of you writing now itself. Anyway, we are going to discuss crash course before ESA exam. Okay. So what we are telling, please listen. Same pattern. There is no GK aptitude reasoning. 100 marks completely full of nursing courses. Okay. Same examination pattern is same. MCQ pattern is same. I think you have good this one experience for the last week for the attempting the prelims, and the qualifying criteria also the same, which you can see that NORCET examination 50% for unreserved, OBC 40%, SC ST, and sorry, OBC 45 for OBC, 40% for SC ST. So be very clear about your cutoff, what you have to score. Okay. So this is based on this only you are going to for the test series session. Okay. So program hosted by Delhi and branch. Okay. So this all you know that. So this is what I've scheduled, and very happy to announce you that we are planning good schedule in the upcoming 14 days. Okay. Let us see how we can work out. So you are going to join with me completely MCQ session, because today, this time I'm going to give MCQ session, magic pill session, which new questions only. Okay, based on the after seeing the prelims, we got a somewhat idea what may be the questions pattern. Let us see. We will work on that. So this is what actually the course schedule. There is a 12 days live content revision very clearly mentioned here. Okay. Yes. So they given percentage. Yes, it is. I think this is will be the percentage only. Let us check. I didn't notice this. Final result will be the percentage only, I think. Let me check. Yes, they have not mentioned about any percentile. Percentage marks in NORCET exam will be 50%. Yes, same relax should be applied and no further relaxation standard. There is no percentile. Okay. Yes, no percentile, because this is the main exam, no. So you don't have any this one. Negative marking same. There is no doubt. 0.33 negative marking is there. Okay. So you have crashed this much. You came and cracked out of 84,000 people. I think nearly 7,000, 8,000 people you shortlisted. Happy for that. That confident you have to follow in your upcoming exam. Very simple. If you are studying yourself also, no issues. We don't have any issues. If you are studying with us also, we have some technique, and you can see today's session. So based on the prelims chapter, I framed some of the new updated this one, because many basic practical people are not aware of that. So I bring my complete 10 years of experience clinically, and now I want to add many practical things which I want to cover from AIIMS Department of Medicine, where I learned. Sometimes you see the prelims question paper where we also not expected they will put a question very basically. If we are writing, we will be writing all the questions mostly right practically. But many people are from not in the practical background, so they may feel difficult, and they given the negative marking also. Okay, so this is what actually course schedule. If you have any doubt, further queries, you can have chat in the group. Okay, so the session will start from magic pill session will start from Tuesday, and tomorrow the session will start 3 p.m. Okay, so I've given the detail. So if you have any doubt, you can this one. Once again, I congratulate for all the students, those who have you learned many things. How you attended out of 18, how much first section, second section, third section, fourth section, and fifth section. So how it is a new exam pattern, maybe some interesting pattern for this. So same thing, you have the confidence and go with your upcoming mains. Practice the 10 series which we are going to give, and what we have focused, the question paper will be, we are planning to give little tough only. Okay, not like simple. Let us see how it will go. Okay. Okay, so now I'll go for the session. What I prepared today for your clinical skill, because every time we have to change the somewhat important. Yes, just a minute. Okay. See, prediction is always important, which see the content which we made after seeing the prelims, we also working for the content. Yes. So some of the pattern which we have changed for the clinical skill, there may be a clinical skill with the quick revision of this pattern. So I think it is visible. Am I right? I think visible. So what I am going to discuss now, after seeing the prelims, everything is a very simple basics, needles, syringes, dilution. Okay. Maybe we have to prepare both actually. What happened? We study very deeply and basic question. Those who are in the clinical, they have written. Those who are not in the clinical, they got stuck. So this time what we do, I'll maximum try to cover the basics, which as per the prelims pattern, we cover the basics also. What is the needle size and so on, so everything, so that you get a confident, and then we have go for the tough questions also, and small content revision quickly, how maximum you can do it. So as per the daily schedule, we can finish the content also. Okay. So what I framed, this may be 3 or 4 PDF I bought for your revision for the demo. Same PDF will be covering the upcoming session. So it will be easy. Maybe if the pattern for old students, it may be difficult because you may be studying from the slide. But still, I may focus the MCQs, which is very important. So IM injection, we have seen the questions are coming, right? Is a track method, which is no, how the question came. Okay. When you go for this IM injections, what kind of needle size we are using for vastalis lateralis? So prediction, vastalis lateralis and the delta if you use, delta adult if you use, and the ventrogluteal we are using. If ventrogluteal if you are using, what is the size? So here, what is the what is the most important? So basically, location varies based on the age. Okay, so you all very clear in that. Ventrogluteal and vastalis lateral for children, deltoid and dorsogluteal also, sir. In that itself, we can come to know which is the least preferred site. My question is, I always put a question, which is the, among these 4, which is the least preferable site? Anyone? How we are going to frame the question? Deltoid. How they go? Only one simple question I put. Which is the least preferable site? IM. So upper dorsogluteal you are putting, you are putting dorsogluteal. Mostly if you are going for the back side, ventrogluteal is a common side. So why you are go for, yes. Which ventrogluteal, dorsogluteal, why we are, which you are using, ventrogluteal or dorsogluteal most commonly in adult? Simple question I discuss pandra, that will be good. Ventrogluteal, yes. So in your question you can frame, which is the least common site is your dorsogluteal. Okay. Remaining all we can using for children, and this dorsogluteal is least common site. And if you see that once again, when you are giving, you have seen you are going for giving medication administration, which of the following is a priority intervention? Okay, what all thing you have to consider? Age, yes. Based on your prelims preparation, age, medication type, medication volume. Okay, and patient who are obese may require longer needle. What is emaciated? Sorry. What is who are comes under emaciated client? Who all came at emaciated client? Malnourished, lean, yes, yes. So in you get a clear MCQs, which even we never focus, even though we have the content, because we also not thought your question may be this pattern. Okay. So let us try with the same pattern. Clinical skills, we can try the same pattern. Maybe it will take 2 days. so that we can cover the clinical skills, and then we can go for the theory part as well as your image questions. Okay. So you can consider here, which we have given the question, when you are giving the medication, which of the following is a priority? Consider age, medication type, medication volume, and patients who are obese may require longer needle. So needle size very important. Needle should be inserted at 90-degree angle, which you all very clear about that. Here I've given the needle sizes with based on the inches, and when you see, we have plenty of gauge, right? 16 to we have 16 to 26 gauge, which we are using needle size 16 to 26 gauge. Okay, so IM needle are mostly blue color, which we are using. Based on that, inches also they can calculate 1 to 1.5 inches, and the size 5.8 to 1. So delta, they have the vasalis lateralis, the needle size is 5 by 8 inches, and delta is 5 by 8 to 1/4 calculation. In adult ventrogluteal is 1 to half inches. That is actually, if you see, they give sizes color coding, which we'll discuss in the tomorrow session. So I have the images of this one. So blue color needle, which we are using for IM. Am I right? So blue. So what may be the gauge for the blue? So in the Mari, some typical question if you put, then only we are 22 or 23. Good, 23. Small thing which you should very clear. Small thing. Okay. 23 exactly. 23. Good. Blue is which is 23 exactly. At least you should know this basics. Okay. So blue, which is 23. And actually, when the gauges are increasing, will get when the gauges getting decreased, like 18, 20, the will get increase. Okay, will get increase. So that is actually we see the image-based question. In the images I added. So needle sizes, somewhat knowledge you should have, and the positioning, vessels lateral for the children. Okay, ventrogluteal for the adult. And now you know that they're asking the supplies, which all the equipments to be get bedside when you are giving IM injection. Very simple questions. They may put a confusion even when we think the same pattern you prepare. So these are all basics which you keep. Okay. So yes, gloves, PPE. Yes, gloves. Whether you keep sterile gloves or clean gloves, what type of gloves you keep? Yes. Yes. Clean. Okay. Yes. And the most important is medication administration record. That is MAR. Okay. So these all things which before going for IM injection, what is the priority? Check medication administration record, the first check. So in the Mardhan question you get, you are in prelims. So medication administration record, you have to check what kind of medication, what ML, everything. Then one by one, knowing the action, indication, consideration of medication to be administered. And then only we are going for perform hand hygiene, and then gather medication from and prepare medication for one client at the one time. See, these are all very difficult to study only, I know that. But after seeing the prelims question paper, we have to work for this also very hardly. So we prepare. Check the medication with the medication administration record. Once again, check, cross check. First, you have to check what medication they've given, and then cross check, and then expiry date, perform calculation, and scan the bar. It's based on the international guideline. Now we don't have any barcode. So once one by one, they are giving planning, and they go for finally perform hand hygiene, provide privacy, and this was the question. Yes, am I right? This is the question of prelims. Yes, when you are giving medication, what is the priority? You will check. Yes or no? Yes, anything, blood transfusion or anything. Yes. So client privacy, that is client ID, check medications, client name and date of birth on the medication admission record. Actually, date of birth in Indian setup, we are not checking. But client ID and medications, clients check medications, what they given, client name. This is the three important thing which they given. Okay. So every procedure, you point out the key. key point. Okay, clean gloves. Some people not in the clinic, they don't know what is clean gloves and what is sterile gloves. Sorry, there is some disturbance. Okay. Yeah. So put on the clean gloves. So you see what is important for your clinical skill. Okay. Yes. So basically, people clean gloves and sterile gloves, where to use and all, you should know. It may be very simple for you, but before the exam, before the exam. Okay. So one by one, you can see the displays the skin in Z-track method, which you all know that. I hope we have seen the images there. Okay. So then you can see the important point. Wait. So one more key points as per the guidelines. As soon as needle is in place, use the thumb and forefinger of your non-dominant hand to inject the solution. See how the questions, when you are giving IM injection, which of the following is true? Because this is a very basics before going for med search. Okay. Some of the important area we have, I focus point number 16 and point number 9 and point number 8, which we have said already. Okay. So as soon as needle is in place, use the thumb and forefinger of your non-dominant hand. That is what we are using daily. But when the question comes, we are getting confused. Wait 10 seconds before withdrawing the needle and withdraw smoothly and steadily. So we are not aware of this. We usually do wait for the exactly 10 seconds. Apply gentle pressure to the site. Do not massage the area. So this is another key points which you all know that. Okay. So one by one, finally discard equipments and then perform hand hygiene, remove gloves and PP, document everything. So what we do, IM injection is very simple, but when you go for book picture and procedure, that is what the question which we have seen in your prelims. Okay. So this is actually, if you see 1, 2, 3, 4, 5 important key points. When you go through once, at least you get an idea what is important and what is not important. When you come for documentation, people should get aware of right medication. We have at least 6 right patients, right dose, right route, medication, right time. Everyone should know this one. Medication route of administration, rights, medication rights. They have to be right patients, right dose, route, and medication, time, and documentation. In the Mari, when you study here, it may be simple. Question paper, it will get complicated. Same question can come. Which of the following is not right included in the medication administration? Not included. So right patient, dose, route, daily we are using this, and when you come question paper, it will be difficult when the give the 2 patterns same. Right medications, right time, and right documentation. Okay, so this is the 6th part which you know compulsory before giving the medication. Finally, we have to document is very important. Right time, right medications, right dose, and route and right patients. What is the documentation down? Record the medication, date and time. Usually we do site where we given. These all it's important thing. If the client refuse, you can if you held or omitted, you have to write an ongoing assessment evaluation after the administration of medications, because you know administration of medications and antibiotic, you get very important. That may be some of the reaction. You get hypersensitive reactions. So what is a special complication? Expected complications, pain and swelling at the injection site. You may first question you can put here. The nurse has given the IM injection, as well as after that, the complication of expected complication of the IM injection. So usually when they give all together, we are getting confused with 1 or 2 options. So pain and swelling at the injection site is expected. Hypersensitive reactions to the medication can be there based on the drug which we are using, penicillin groups and so on. So, okay. And the slight fever also maybe comes under complications, and monitor client for the reactions continuously. Okay. So pain and swelling at the injection site. Okay. And hypersensitive reactions, massage we should not do for anything. Pressure only we have to give. We should not massage. That is what mistake we are doing. Okay. So we usually by practice what we do, we massage. In the book question paper, if it comes, we also go for the same option. Okay. Do not massage. Okay. So these are the some of the complications for the injections when we give pain, swelling, hypersensitive reactions, slight fever, and monitor client for the reactions. So finally, this is very important area where you get a question of IM injection. So IM injection sizes, route, and which is a priority. What is the supplies? What will the arrangement you do? Clean gloves or sterile gloves? What all thing you necessary? இதுதான் வந்து important nowadays as per the prelims what I faced. Okay. Next, intradermal injection. So intradermal injection, what is it? Mar, please explain. Those who attended section, I think he joined. When you have joined now only, I think. What is Mar? Yes. What is Mar? Medication administration record. Good. Okay. First, you have to check what kind of record they've given. Now I am intradermal. Intradermal is very fast, rapidly. Which is the rapidly than the oral route of administration? Which medication route more rapidly than the oral route is a ID. ID, if you see that this is international guidelines. Forearm location, consideration same age, medication type, medication volume. Tell the client where there is a small wheel, and this is your question. This is your question. ID after giving the intradermal, practically if you see. Tell the client there will be small wheel when injected that goes down over the time. That is the expected wheel is expected finding. Ensure the client knows to come back 48 hours after injection to assess the induration. That is all. You all know that. Assess the client risk for the tuberculosis. So for ID injections, mostly we are giving for Mantox, I think so. You all know that. Apart from that, ID we are giving generally for this one. Any test dose we are giving, we are using for practically test dose. If you want to give for before any antibiotic, we have to give intradermal. So intradermal, when you give, tell the client that there is a small wheel when injected that through down over time, and ensure the client should come back 48 hours after injection to assess the induration. Okay. So that is what for tuberculosis they have separate guidelines. And apart from allergic reactions, we know. Okay. If allergic reaction will come to know. Now, needle sizes mostly we are using 25 to 27 gauge. That is 1/4 inch to 1/4. If you see that intradermal needle gauge, directly they may give question. Okay, intradermal needle gauge. Okay, intradermal needle gauge, and same like equipment, same, and everything is the same, and clean gloves, everything. And we can check once again. First, we have to check medication administration record. And you see what kind of important thing, same medication with second check, we have to always cross check with twice before giving the medication. That is also important, which we have to do, but we are by practice, we are not doing. So when the question comes, you have to know. Transport medication, keeping them slide at all times. So in front of us, we have to keep. And once again, you get a same check ID, check medication. So only this question was done in the prelims. Okay. So not everything they are given. Selectively what is important, they are given. Then forearm, we are going for the site, and position the client only exposed area needed to perform the procedure. So needle into the tissues 15 to, yes, you all aware of that. Intradermal should be 15 to 5 to 15 degree. Usually what we do, we usually not discuss this kind of chapter because this is the basic we feel. And after seeing this question paper, I think we have to study the basics also. So sometimes I think after the basics, like 5 to 15 degree angle insertion, as soon as the needle is in the place, use the thumb and forefinger, non-dominant hand. See, once again repeatedly comes point number 15, point number 9, point number 8. Okay, these are all the MCQ point. And point number 16, wait 10 seconds before withdrawal the needle. It is a standard one which we are following for the injections. Okay, apply gentle pressure to site, do not massage the area, engage the safety shield, and do not recap needle. Yes, you all know that. Hope so. Recapping should not be done. So mostly it is very important. Never recap the needle. I think this is all done 6 years before also. Do not recap the needle in safety, because recapping during needle prick is there. So we should not recap. Okay. So based on that, document and evaluate. Here also same, record the medication given, record date, time, site. Okay. And if client refused and omitted, you have to assess. Same complications. Okay, pain and swelling, hypersensitive reactions, and monitor client for the reactions. So here the question is, what gauge mostly they are using? Okay, so what gauge they are using? 25 to 27. Okay, that is what actually your question which you may get. Okay, in the intradermal. Intradermal, we are puncturing the epidermis, skin layer also you should know. Outer layer is epidermis and then dermis. So we are touching 15 degree, we are inserting into the dermis. Okay. So bus, only 5 to 6 key points which we have. Okay. Come for the CVP. CVP, we have plenty of questions which you all know that. So there's plenty of practical guidelines for the CVP. So deliver the it is a hyperosmolar solutions which you have more than 900 milliosmol per liter, because more than 900 they have. So that is what actually severely hyperosmolar solution. Okay, so it's very important. TPN and yes, CVP, we are giving hyperosmolar solution is TPN. Okay, and insufficient TPN to give multiple IV solutions. So first thing you should know after the CV catheters, check position by the X-ray. It's a confirmatory. Which X-ray? AP view. Okay, not a PA view. AP view is commonly used in the clinical. Okay, AP view is commonly viewed in the clinical. Okay, AP view. And then you have your this very important part. Catheter might be single or double, and you see, yes, triple lumen is very important. So catheter is very, you can see that whether we are using triple lumen and double lumen and all, we see catheter is inserted peripherally into either the basilic or cephalic vein into the superior vena cava, inserted centrally into the internal jugular vena. So we have the types which we study one by one. PICC line is there, tunnel catheter is there, and we have studied already in your previously prelims preparation. But here, separately, you study where you can give the injections, which area is most commonly. Tunnel catheters are very important. Tunnel catheters are double, yes, DLJC, okay, double lumen jugular catheters. So this is all the practical thing which you should know. Double lumen jugular venous catheter. DLJC is your tunnel catheters. You can see only 2 port which is used for the dialysis part of anything. Okay. And you see more permanent use for long-term IV therapy, maybe single or multi-lumen. So patency is maintained by flushing the catheter with the diluted heparin, Q8 hourly. Okay, every shift we have to flush this. That is what very important. Practically, you should know, not 4th hourly or BD or Q24 hours OD. Okay, those were not in the clinical. Every shift Q8 hourly we have to do. And surgical implanted under the skin, very important. Usually the tunnel catheters are safe actually compared to the triple lumen. Triple lumen have the more risk of the CLAPC. CLAPC is most commonly seen in the triple lumen, but tunnel catheters, they don't have that much of infection. And you see, used for long-term IV therapy and assess for non-coronary. Patency is maintained by periodic fluxion with the heparin. Vascular access port implant. So what is this 2 types which we are using? If you go for the clinical, one is triple lumen, which is most commonly using, and tunnel catheters are vascular. Tunnel catheters usually non-tunnel tunnel differentiation. You all know, tunnel only they will surgically implant under the skin. That is what tunnel catheters, vascular access port. Okay, and PICC line. If you see PICC line, so central venous catheter. What was the question in your exam? Supplies is your question. So supplies, 5 ml syringe is most commonly kept in the central venous catheters, which is it is there in the kit itself. Okay, 5 ml syringe is used for the flush. Okay, so that was a question which you had. Yes, not 10 ml. Okay. Okay, so here PICC line. So even if you triple lumen or double lumen, anything, 5 ml flush we have to do, and PICC line it's a 10 ml flush. So in the Mari questions also we have not expected, but still 10 ml flush is used for the PICC line. Used for long-term IV therapy, and which is I told cephalic vein, and we have cross-checked actually both the veins which you are using, but international guideline they given basilic vein is most commonly used. If you want to update, you can update. So PICC line, which is very important. Which vein is used? Basilic vein. The catheter is inserted so that tip is terminated into the. Yes, they may ask where the PICC line is entered. PICC line, they start from here and ended in the, yes, it is terminated in the subclavian vein or supravenous cava, not entering into the right atrium. Everyone should know where the PICC line goes. Okay, where the PICC line will go. Okay, it is terminated in the subclavian or your supravenous cava, but it is not going into the right atrium. They may ask you PICC line where it is going, the tip of the PICC line where it is ended. Okay, so small amount of bleeding during the incision are common. Expected finding, that is what actually you should know the nursing intervention. The small amount of bleeding during incision are common. If bleeding continues after 24 hours only, we have to be very careful. This may be your exam question, which you all know. When we are inserting PICC line, bleeding is there, small amount of bleeding. So inform to the physician, document the finding. So small amount of bleeding during incision are common. If bleeding continues after 24 hours, then we have to inform to the physician. So phlebitis is most commonly seen here, okay, in the PICC line. Then you have question in your epidural catheters, which it's a non-central tunnel, which is epidural area they will be placing, which we have studied in the prelims also. At last, we have studied in the LMR also. Place the epidural space in the spinal column, used to administer analgesic. Analgesic specially. Assess the client's vitals and respiratory status, very important before doing this epidural. Incision site for the infection. Infusion device properly rate and flow is very important. And the question is, this is the question. Before giving epidural, this one, anesthesia, so aspiration is performed before injection. If more than 1 ml of clear fluid or blood is aspirated, do not give the injection. So, our key points everywhere, one key points will be there. Epidural means, epidural may we get one key point. Okay. Aspiration is performed before injection. If more than 1 ml of clear fluid or blood is aspirated, do not inject the medications and notify the physician. So MCQs. Yes. The repeated question from the central line. Central line incision, tube changing and line removal, client should be placed in the terminal back position or supine. Also insect the client to perform the Valsalva maneuver and to increase the pressure in the central venous when the system is open. Okay, so this is, you can see that last year before your question, during the removal, what may be the positioning we can use. Okay. Incision, during incision, tube change and line removal, client should be placed in the terminal back position supine. This is a very important. Also, insert the client to perform Valsalva maneuver to increase the pressure in the central venous when the system is open. So apart from that, central line, we have plenty of things which we'll be studying. This is the practical setup which you know about the difference between the tunnel. I have not discussed the triple lumen because I've discussed only your tunnel central venous catheters. That is comes under vascular access port and the PICC line and the epidural. Okay, triple lumen we'll discuss in the slide in the coming session. Okay, triple lumen is mostly we are using. You can see this is what actually we exclude this one, but I have not added triple lumen because triple lumen is everyone mostly knows and we can discuss in the upcoming session. Okay. Come for the subcutaneous. So subcutaneous is another important part which you all know that to give medication more rapidly other than the oral route, that is also one more thing. And you can see where is the most common site. Yes, subcutaneous, as I said, always abdomen is the preferred choice, and then come for the thigh, and then lower back and upper arm. Least side is your upper arm, but most commonly we are using upper arm. Subcutaneous, if the question comes, which among the side is the least side, though always question come this pattern, least side, upper arm, that means your deltoid area. But number what we do, we give mostly subcutaneous there only. Okay, mostly subcutaneous injection should be abdominal, thigh and lower back. Okay, and once again, intradermal needle and subcutaneous little variation is there. Needle size 3 by 8 to 5 by 8 inches, that is 27 to 27 gauge. Okay. Yes, abdomen avoid the pregnancy. Why you want to give an abdomen? Okay. So Beta for diabetic. Beta means that is a pen which they are using in the diabetic. Okay. Beta is your subcutaneous needle pen which you are using for diabetic. Okay. The trans illumination category other word okay. Very simple question. That is very simple question. Trans illumination. Vein illuminator is otherwise known as trans illumination. But what to do? We have not expected that and all they'll give. Okay. So we know that that is a transformation for IV, but still bypass for the diabetic pen. So what is the needle size for the diabetic patients? So that may be gauges goes little minor, like small 30 to 31 gauge, 1/3 inch needle size, 1/3 inch needle size, and with the ultra fine small thing. You have seen the diabetic patients who's taking, okay, small subsets, very small as well as inch, okay, in the pen. I hope everyone knows, okay. Which is the most appropriate settle? So you can give for thigh. Thigh is there, no? Okay. This was a question prelims. Then it's a thigh is there, no? Abdominal, no thigh. You can see the marking here. Okay. So here next consideration I forgot. Consideration, you see age, medication type, medication volume is mandatory. Tell the client to rotate the injection. Yes. Whenever subcutaneous injection we are giving advice, we have to tell the patients to rotate the injection to avoid hardening of the area. Ask the client which side they would prefer. So always we give here, here, and here. Alternately, we have to go with the subcutaneous injection. Okay. Okay. See, as per the diabetic needle syringe, they given twice, 1 or 2 days, not more than that. Okay. So every time they some 48, if they are going for OD dose, they can use for 3 OD dose. Usually, if they're using regular insulin TDS, 1 day is enough. It is based on the dosage. OD if they're using 3 days. If they're using TDS dose, 1 day is enough. Okay. So yes, insulin pen holding degree. How we hold the insulin pen holding? It is a subcutaneous. I am in 90 degree or how? 90 degree only we have hold because needle is subcutaneous. In the questions vanducha. The question was there in prelims. Everyone is asking where you got a question. Okay, mock test. Okay. 90 degree. Some people said there is no question from the mock test. 37 question were there from the mock test. We have marked the question and kept question number 2, 6, which test series. 37 exactly. Karthi sir have given the list. This all the question were there. Okay, 37 questions. Apart from that, our slides, my slides, especially section tracheostomy, ET changing, and whatever I said in the practical, it was there. Okay. So some things this is what you have to change your habit. Nowhere they give the same question in your question paper. Okay, prediction. You have to image this pattern can come. You have to go and eliminate the option. Same question Gurtana, then it will be difficult for them also. Okay, same question. They will be changing little wording. They will be changing the wording, but same question they won't give. Okay. See, if you see, this is the key point. Okay, you know that. Tell the client to rotate the injection site because subcutaneous needle now. I think after seeing the basics, I have to teach every basics. Teach the client to rotate the injection to avoid hardening, as well as if you see that diabetic recommend using 30 to 31 gauge 1/3 inch needle, which are ultra fine. Okay. Now. Clear. So here you got this equipments, gloves. Once again, same. There is no change in all the injections. Right patient, right dose, right documentation, try medication, no change. And the procedure: check the medication administration record. First check, know the action indication, consider perform hand hygiene. Then second check, and then go for the medication. So what is important here in subcutaneous? Let us check. Once again, you see the question say ID. Check medication client name. இதுதான் இம்பார்ட்டண்டா கொடுத்திருக்காங்க ஃபோக்கஸ் பண்ணி. Put on the clean gauze and once again remove the needle cap, inject the needle. Yes. இங்க இருக்கு பாருங்க ஆப்ஷன் 90 or 45 degree. If you are using directly pen and all 90 degree we can use. If you are using subcutaneous needle, if you are using IM needle in the subcutaneous, then we can use 45 degree. needle illana. But if you use these all the practical, if you use a 5/8, as I said, 30 to 31 gauge needle, small needle, subcutaneous needle, now directly we can give an IM. Okay. Once again, the same guidelines, wait 10 seconds before withdrawing the needle and withdraw smoothly and steadily. Okay, apply gentle pressure to the side, do not massage the area. Okay. Okay. So this is what actually same thing which we have seen. So complications are same. Okay. Now it's your dosage. Dosage. Very simply, more null questions from the dosage. I think everyone have answered. Same pattern we can go. IV drips, the clue which we have to know. When calculating the how many hours or how many long the infusion should go, there is no need of drop factor. These are key points. Okay, drop factor we should not add. If the question is how many hours we have to give, how long the infusion should be done, you can see that when calculating GT per minute, then only we have to calculate the drop factor. GT la kudutanga drop factor. So illana you can see how much ml per hour total amount update divide panna. We have to divide total amount to be infused by how many hours should be infusion run. Say example in the same question, infuse 500 ml over next 120 minutes by infusion pump. Okay, so directly we are giving 120 minutes 500 by 120 into 60, that is 250 ml per hour. Some of the questions are very simple only. Okay. Say 10 second, you think that 10 second, what is the meaning of 10 second? நீங்களே யோசிச்சு பாருங்க, ஒரு IM injection கொடுக்குறீங்க, when we give injection, okay, 10 seconds is not a maximum. At least the injection should get completely from the needle, all the injections should get enter into the tissues. What an insert, just remove, then what is the fine? There will be some this one damage to the skin also. We have to wait for 10 seconds and we have to remove slowly. That is the reason why they're given. And also mostly all the injection, see when you are giving through the syringe, this is your needle. Okay, injection is going in the needle. So some injection, all the injections should get entry into the tissues. Okay, then slowly we can withdraw. For that also we can tell. Okay, so this is not a big rationale for this one. Okay, 10 seconds is not more also. It's not a 10 minutes, 10 seconds. Okay. Then 500 divided by 120 by 60, you can see that directly there. Okay. Then if they give ml per minute, then it is very important. Total amount to be infused is all you know, hours into GT factors. So calculate IV flow rate of 1500 of NS to infuse of 7 hours. The infusion set is calculated for drop factors. In the Mari Kurtan, I think this is a basic question. We all know that. Okay, 1500 by the 71 into 20. I think many of the people have given the right answer. Those who are preparing this not aptitude reasoning, as I said. This is very simple calculation only. Okay. And the calculation from the antibiotic, give patient 400 mg of vancomycin in 300 ml of dextrose to infuse at 10 mg per hour. Calculate the flow rate. So in the Mari, if you give flow rate if you want to calculate, so in ml per hour. So they've given 10 mg per hour. 10 mg per hour, IV rate in hour or volume, both we can take. IV rate 10 mg per hour into volume that 300 ml by total mg. Okay, in hand. How much volume? Direct question, no? This is also direct question. GTT Gurute, how much infusion set is see, before question is IV flow rate of ml, so and so, and draw factor they're given. This is antibiotic desired dose, available dose into ml. Okay, very simple question only. That is 7.5 ml. So idala you should not lose the MCQs. Very simply to answer. Okay, only dopamine people will suffer. But these all the questions are very simple only. Tablet also same. You will have the dejection dose this much given, and what is the available quantity, dose into supply. So if a doctor's ordered lorazepam 50 mg per day, and the pharmacy is available form is 100 mg, how many tablet would be given? This all the question came. Very simple question. So 5 by 50 by 100, 50 by 100 into this one. Yes, tablets how much? So you get directly how much tablet? So 50 mg divided by available form. Okay. So that is a 0.5. Okay. So pediatric also small calculations, always weight kg by pound. Maybe if you want, in the international guidelines they're given, but Indian setup generally use the same formula for same dose, weight per kg into dose per kg. Simple. If you want, I'm not a pediatric, maybe pediatric faculty they'll be taking, but still write the formula weight per kg into dose per kg equal to amount to be given. Use this formula for the safe dose. Very simple. Weight per kg into dose per kg. So இங்க பாத்தீங்கன்னா healthcare workers are ordered 250 mg of meropenem to be taken by infant weight of this so and so, or weight Indian setup in the மாதிரி ஒரு 20 kg and something every 8 hours. The medication label is this much. Is this order within the safe dose range for this medications? So some of the questions which safe. So if they want to calculate based on that, so if they go for the weight per kg into, so 150 mg where it is given, already they given 150 mg into dose per kg. Dose per kg we have found it already. Okay, so they get this much of dose is per day safer. Matlab, how if you give meropenem, maximum dose is safe for the child. Okay, if we go for 75 mg, 75 into 7.3, this is per day safer side, minimum, maximum safer side. Okay, so based on that, they go for some of the question, but still you may study in the pediatric. Okay, so this to calculate the safer dose. What should do when 2 IM injection need to give? Use same side or different side? Each injection. இதெல்லாம் கொஸ்டினே கேட்க கூடாது. You should never ask this kind of question. If you completed your graduate BS nursing, it should be very clear. இல்ல doubt, there should not be doubt in this. This is different side. Very simple. You should never have doubt if you have the degree. And so these are all the basics actually. You never give the same site IM injection. Okay, it should go with the different site only. Okay. Then you come for here. This is a safer dose calculation. You can study in pediatric. So I've calculated. I've discussed only 4 important. And further, I'll go for the one more thing, blood transfusion. Okay. Just a minute. It's visible. Is it visible?
So it's visible, sir.
Okay. So if it is visible, you can see that one more question. Even we have studied in our slide itself, but we have not focused very clearly. There is always 2:1 ratio. You can see the circumference, arm circumference, and the this 80-40%. Okay, 80:40%. The length and the width. If you see that arm circumference when they tie, that is what 2:1 ratio is they given. So last time they given 2:1 ratio question, this prelims. Next time they may give, if your arm circumference of child is 22 to 26, what is the cuff size you can select? There is no way we have to go. We also not expect of the question which they given. Okay, but let us study everything. Adult, if you go for large adult, you can see at least 27 to 34 arm circumference. They go for 16 to 30 adult size and cuff size. If thigh, if they want to go for thigh BP, they go for 45 to 55. Okay, so overall 2:1 calculation or 80-40 calculation. 80% is to 40% calculation. They will go. Okay, arm circumference to the width circumference. How they will select the BP, this one. And moreover, we focused only this one. When you go for too small with too small BP cuff will result in elevated falsy reading for the adult. And if you go for too large with giving reading, that go for the too low. This we have studied, but this question and all everyone knows actually, because this is what teaching for last 10 years. So I think BP cuff, if you are using the narrow BP cuff for the adult, that causes elevated falsy BP, even though many people doesn't know elevated falsy BP. Elevated falsy BP. Elevated falsy BP. Okay, if you are using too large cuff with small ring, elevated, yes, falsy low BP, not elevated, falsy low BP. Very important. Before giving the injection, always you have to cross check. These all the things which you have to cross check. Okay. Okay. Nothing. I am after inserting. We are confirming by withdrawal and giving. I am after inserting. We are confirming by withdrawing and giving. But after giving injection, taking out syringe. Yella patient bleeding bleeding will be there. That means your site is not properly inserted. Actually, bleeding is why it is coming. Bleeding after your question is needle bleeding mother when they remove bleeding. Yes, obviously it will be there. Okay, when you are inserting the proper area. Okay, that means you are not damaging your vessels. Okay, when you are removing, okay, there may be some small damage if your site is wrong. Okay, if your site is wrong, because IM needle goes towards the where IM needle where it will go deeply. Intramuscular. See, you know epidermis, dermis, subcutaneous, intramuscular. It goes and land in the tissues, muscles. Okay, so we know the site where we insert. Okay, so when you give IM injection, usually we withdraw and see that is the muscles and tissues. That is the area where we are focusing, that upper outer quadrant of dorsal or some all the IM injection area where the blood supply, this vein and the supply, we won't prick that. But when you are withdrawing, what happens? It comes towards once again subcutaneous and so on. So there will be if your site is changed, like suppose I will tell, if your site, suppose this is the upper outer quadrant. Okay, this is the upper outer quadrant. I'm giving here exactly upper outer center. You are giving here. Okay, when you are inserting, okay, when you are inserting here, there is no bleed is there, and when you are withdrawing also no bleed is there. Sometimes won't come, but most of the time it come because it damages. When we are withdrawing, what happen? The needle will get damaged. That when needle is going inside, it won't happen that much. When you are withdrawing outside, surely there will be some tissues damage will be there, not blood vessels. Tissue damage will be there. So that is coming in your this one bleeding. Okay, syringe, if a needle, if you want to come, it should go and touch the vessel, blood vessel. If you touch a blood vessels only, it will come in the needle. If you touch in the muscles, the needle will be sometimes you feel very difficult to give also. If you are not maintaining the proper positioning and this one, what is that exact area? Okay, supposing if you are giving here, somewhat here, so our location is upper outer quadrant. This is the upper outer quadrant. Maybe I am given here upper outer quadrant. What I feel many times, even we also feel many times, 80% patients will get once you remove, there is some bleeding will come. That is only small aberrations or something which happen in the tissues, not in the blood vessels. Okay, because blood vessels, something vein or this one which we are pricking, that is different, and the tissues, and also if it is damaged, also it's some aberrations will be there. Even aberration, laceration, you know, laceration though deep aberration superficially. Okay, so minor, small, tiny vessels will also get damaged. So that maybe leads to the bleeding. See, number one, the only vein we are thinking. Apart from the veins, we have tiny vessels, tiny vessels. Even needle size also won't go inside. Okay, so that may be damaged. Okay, so you are right. You are asking the good question. So that is actually happen for all, not only the special patients. Everyone, most of the people, those who are giving IM, it happens. When you press and see, after that small, this one will be there. Yes. So here BP, in the BP curve, what is the special thing which you have to remember? One is your measurement, as I said. Okay, very a day before yesterday when I'm discussing vital signs, also I said you have to be very clear. Okay, so you have your cuff pressure. Two important thing I want to tell. So when you are going for BP cuff, palpate the brachial artery and place the stethoscope on the point where the palpate the pulse. Put the stethoscope, air pieces on your ears. These all things which you do, but only thing you should know. First, palpating the radial pulse. If you are doing mistaken measurement of BP, then how you see that how we are graduated from the BS nursing? Okay, BP measurement everyone knows. First close the knob, okay, and palpate the pulse and inflate the knob, and slowly this will go higher range. Okay, when it goes higher range, the pulse will get diminished. So we can note that suppose that is 180. Okay, then we are tying the BP cuff and inflating more than 180 to up to 210. We are inflating. That is the guidelines. Watch the gauge. Keep inflating the cuff until the gauge reaches about 30 mm above the expected systolic pressures. So whatever we have seen the pulse systolic pressure with the pulse, we have to inflate more than that, that is 210, and then slowly 2 to 3 mm slowly we have to decrease that, fall by 2 to 3 points, like slowly each beat we have to decrease. Then the first sound Kotakov sound, first sound, which is very prominent, as I said yesterday, before yesterday also, like sound. The peak sound, first sound, peak sound is known as systolic pressure. இதுலயே பாதி பேருக்கு தெரியாது நம்மளுக்கு. First sound உடனே we go and calculate systolic pressure. Peak sound only we go for systolic pressure. And fifth sound, Kotakov sound is known as where the pulse is completely decreased, that is diastolic pressure. Okay, diastolic pressure. Okay. So here the two key important point. One is this one and how you calculate. The first sound is where first sound is your is systolic pressure, and the fifth sound is your diastolic pressure. That is important here. Okay. Apart from that, your BP is known at 1 inch gap. You should know that is 2.5 centimeter. Okay. So I'm not going this. I'll go for the blood transfusion. Okay. Antibiotic and I will discuss in the coming class. Okay. Select the most probable topic I selected. So let us see in the coming session. Blood transfusion medication we have given already. Just a minute. I will go for the blood transfusion sterile kit. What about eye medication, ear medication? Yes. So blood transfusions questions are always expected in your exam. Am I right? I think people are leaving. Okay, so I'll finish it. They need a break, I think. Okay, so some people don't need this and all. They may study it. Okay, so some people need compulsory. So here you see that we have the supply of blood transfusion. We need a supply of normal saline 250 ml and 10 ml syringe. Blood transfusion flush is always 10 ml syringe. Last question, CVP, in this time blood transfusion also they can have, because blood is have good viscosity. We have to flush it properly. Okay, and then the reaction and all we have studied. Before a transfusion, you need to know some individuals have religious preference, do not allow the receive the blood. That is Jehovah's Witness. Okay, that is very rare question. That is all won't come. But typically, blood samples drawn for compatibility type and screening are good for 72 hours only. Okay, so when you draw the sample for the screening, that sample good for 72 hours only in the lab. Okay, so don't let the blood product sit greater than 30 minutes before. Yes, in the question on the I think within 30 minutes we have to give the blood transfusion, not more than 30 minutes. Once you receive the blood, we have to, simple question only, we have to give within 30 minutes, not more than that. Blood must be completely infused within 4 hours, not more than that. Summa practical na. That is a very simple question only. To make confusion, they given 20, 30. Confused, they may be doing the wrong. Okay, so very basic. Within 30 minutes, we have to give. Otherwise, those who have never been in the clinical side, they may not knowing. So, with clinical side, those who are knowing, they may be knowing. Within 30 minutes, we have to return. So if there is any order to give medication with the transfusion, yes, this is a key point here. This time this question may also come. If one blood transfusion is there, you want to give the medication, okay. So very importantly, what you do? So I will started to give. You are going to start the blood transfusion around 8 o'clock. Okay, that is the order of giving medication with the transfusion. So what do you do? We have to start oral medications or anything which we have given 30 minutes before starting infusion. Any medication we can give, but medication should be started immediately 30 minutes and then we can give the blood transfusion. Okay. So administer IV medications immediately before the starting transfusion. Oral medication 30 minutes. I give important here. I give important here. Very important. Usually in the clinical, we are doing this the same. Oral medication 30 minutes before transfusing and IV immediately before starting transfusion. IV catheter should be patient and correct size, which you all know that. Never infuse any other medication the same tubing as that is also you know that. The checklist also very clearly mentioned all the thing which you put on gloves, everything. And moreover, peripheral IV is patient and approximately 18 to 20 gauge is always preferable is in the periphery. Periphery may, if you want to give, better don't put in the this one 22, 24 and all. Compulsory we need at least green to pink gauge needle for the blood transfusion. Once you receive the blood transfusion, verify the order to transfer blood product. Verify that consent for blood product administration has been signed and approved. These are the practical. Request blood from the blood bank and gather the necessary supply. Perform hand hygiene and provide privacy. Confirm the client identity with the 2 identifier. This all we'll do. Explain the process to the client. Educate the client about blood administration and the signs of transfusion reaction. Raise the blood to the appropriate level. Obtain baseline vitals. Perform hand hygiene. Put on the gloves. So it's important. Okay. Just a minute. Yes. So, which is actually I was discussing the same. Okay. So checklist, what all checklist we did? Obtain baseline vital signs and perform hand hygiene, 2% verification, and you have. Okay. So you can see that prime the administration tubing with normal saline. Yes, this is the mandatory. Number one, usually we are not doing. Okay, we have to do it and then we have to give. Put on new gloves and place the administration tubing in the infusion pump. Okay, fine. Flush the peripheral IV with normal 10 ml syringe. This is very important. Central venous line they were asking. This next time they may get a question from the blood transfusion. Okay, attach the administration set to the peripheral IV tubing. Label the tubing near the client for the quick identification. Yes, begin infusion. This is the key point. 10 is the key point. 6 is the key point. Okay, 10 is the key point and 13 is the key point. Label the medications. Begin slowly at 30 to 50 ml per hour and 2 ml per minute. If they are putting the question 2 ml per minute or 30 to 50 ml per hour, and remain at the bedside at least 15 minutes for period for the transfusion reaction. Stay with the client during the first 15 minutes of infusion to monitor the transfusion reaction. After 15 minutes, perform the respiratory and cardiovascular assessment and recheck the vital signs, which you all know that. After 15 minutes, the monitor the client as per the agency protocol. Increase the infusion rate. If the transfusion reactions or infiltration are observed, slow the infusions and notify the physician. One consent only for 1 month. What you are answering? Transfusion chart record mandatory that everyone knows. What you are asking? Multiple trans need. No need. One patient only you are giving. No. Yes, consent is valid 1 day. No. Multiple transfusion is massive transfusion we are using. Okay. Once you are advised and get a transfusion, that is enough. Okay. So then you get a question here, checklist. You can see that what I said, same. Verify the batch between the name and the date of birth and the client's wristband. I think this was the question in your prelims, blood transfusion question. Am I right? Idala IVA. I don't know exactly what you have written. Blood transfusion came or this one? Acha, IV. By this is a simple question why you are asking. Consent is valid for 24 hours. I think people are diverting, you are studying from many content here and there. It's only people are getting many doubts. Basically, you should never forget. Okay, basics are basics. Even when you are arranging the blood, okay, 8 a.m. to 8 a.m. 24 hours only. If you are arranging one point around midnight 2 a.m. second point we have to send this one separate this one cross matching and everything once it completed 24 hours. Okay, that is the guidelines are there. Okay, so verify the match between the name and date of birth. Yes, name and date of birth, ID number, client's wristband, and information on the blood bag. Verify the blood bag identification number, important identification number. Verify the blood type, verify the RH incompatibility, verify the blood has not expired, sign that the transfusion reaction. So very importantly, these are all the things which you have to know. Okay. Always blood transfusion reaction, you get a question. When there is as a TACU, cardiovascular dyspnea, tachypnea, and hypertension and all, if it is there, then maybe that is a TACU. Okay, we have studied in your slide. We can go with that. Here, this is expected fever, flank pain, pleuritis, dermatitis, maybe there. Cardiovascular tachycardia, hypertension, JBD. Okay, and respiratory dyspnea, pulmonary edema, and rails. This may be the TACU. Transfusion associated circulatory overload. So transfusion associated circulatory overload, hypertension will be there, descending jugular venous will be there, dyspnea will be there, lung sounds will be there, pulmonary edema will be there. So that is very important TACU here. Okay. The key point is your NCLEX tip. Do not flush the line if the patient reaction is suspected. Yes, this is very important to avoid any further blood clotted administration. So you should not flush. Okay. Okay, TACU or PRELIMS. Okay, TACU is very commonly they will ask either TACU or trolley. Every time they put a question, trolley or TACU. Okay. Sonna question da vanduchi. There is no way questions. I have seen the question. 65 questions are what I discuss mostly. Okay. Otherly people getting some of the questions you have to apply your knowledge. Trial feeding, how much ml you have to give. That is a 50 ml. Okay, which you are using syringe, 50 ml syringe. So you have to apply your common sense, critical knowledge. Not every questions will be same. Anyway, you people have cleared the exam, well and good. Maybe some critical knowledge you people applied. Okay. So same critical knowledge you. Okay. So see, do not flush the line if patient transfusion reaction is suspected to avoid further blood. Do not flush the line is different. Giving the NS is different. Isotonic solution, flush is different. Flush will be very fast. It will be spreading very fast. NS maintenance dose we are giving. The crush dosage is different. Dilution is different. And what was the question there? Okay, if people have cleared the exam. So crushing and all, only they've given dilution. If they give it is 50 ml only, no 30 ml. Okay. 15 to 30 ml, we won't dilute the drug when you are giving relative feeding. At least 50 ml range, the relative fluid should be diluted properly and it should be given. Okay. Pediatric, I don't know. Adult only I've given you. Pediatric, I don't know the question that we discussed in the pediatric faculty. You ask in the pediatric faculty because I was in the adult department. What we do in adult, I'm giving. Okay, without knowing if I tell, then it is difficult. Okay. Okay. So the remaining blood transfusion, trolley and all, we'll be studying the upcoming quick content revision. Anyway, I'll be discussing the content revision. Okay. Okay. So let me check which is important here. PICC line and all, now people are not aware, right? So basilic vein PICC line, which you are gathering all the equipments, Okay, so we perform the hand wedging. Key points: extend the limb with the PAC place in the dependent positioning. Dependent means comfortable positioning. Okay, hand. Yes. So I'll put a key points. PICC line procedure. Uh, yes, remove the stabilization device and be careful for dislodged catheters. Inspect catheter site and surrounding skin. Measure limb circumference above incision site and compare to the baseline. Point number 7. Measure external PICC length and compare to the baseline. Point number 8. Those who are not seeing the PICC line, they may feel very difficult. But still, you can try. PICC line is mostly important for intermittent chemotherapy and all they use. Okay. Most important is you can see that this one. Inspect dressing every site over 4 hours, and as per the fact 4 hours, Q4 thirdly, you have to see the dressing because it's a very minute tube which is we are inserting into the basilic vein, which is going towards the inferior vena cava and then going towards the subclavian vein and going towards the touching the below the right atrium. Okay. PICC line dressing and central line dressing is weekly only. When wet, CLAPSI central line dressing also I discussed in the class 5 to 7 days weekly. Here also PICC line also weekly. These are all the minor questions they can put. How many days PICC line dressing should be changed because we are not aware of PICC line. PICC line should be dressing changed in the 7 days weekly once. Okay. Remaining all same. Okay. What is the question in ostomy? Any question from ostomy? Compulsory they will give. Okay. Anyway, I'll prefer for this upcoming this one. I'll discuss in the this one. Just for your this one, let us go with this. More thing, artificial medications. Health education. Okay. Mostly health education or care they will be giving. Am I right? This should not be no soap and water. I told that you should not use this one. Anything we should not use. I'll discuss this one. I forget. Other questions I think came. Emollients, no? Yes, you can see here, less is more. Often only water is sufficient. If required, use mild soap without fragrance and dyes. No, do not use lotions, creams, powders, baby wipes, isopropyl alcohol, steroids, medication, ointment. Either way, nothing should be used. If skin and ostomy abnormalities occur, manage care properly and contact the provider. Ensure the client understanding about colostomy and skin care. Okay. Fluid intake will be the right answer. Okay. Colostomy patients, ileostomy patients, or ileostomy patients, the fluid volume deficit will be problem. Okay. Uh, 5-year-old child. Colostomy, yes. In the questions, what is the doubt? Whether it's a sterile or clean procedure. It's a clean procedure. It's not a sterile. Okay. Sterile, it's not a sterile. Every day they can do in their washroom itself. Okay. It's a clean procedure, not a sterile. Okay. Okay. Anything else you can discuss? Otherwise, we can go for tomorrow session. Okay. Anyway, I have the confidence that you have cracked and you are in the moment of going for another 10 days. Be careful, and whatever you studied, I think some of the 50% students have knowledge now. Those who cracked your prelims, okay. Without that, it's not possible to crack out of 80,000 people. Okay, so I congratulate once again. But at the same time, you have to be very careful in your mains. Okay, so I'll try to put my best level to prepare, but let's see how it goes. Okay, let's play. Okay. Anyway, we'll be having a good pattern of this 14 days. Apart from the old content, some of the question series and morning sessions I'll update it for your knowledge. So let's see completely the different session in the magic pill. Magical pill session will be different. Okay. So you'll be having the scenarios and one direct MCQs. Okay. In city choice, you choose. I think institute preference, city choice already they're given. I think 21st today is the last date. Today or tomorrow's last date. Okay, so hope that this content will be more useful in the upcoming exam. Okay. Okay. This is 14 days session. It should go fast only. Slow session. Okay. If you think recording we are giving slowly, slow sessions won't be there. We can't cover everything. Okay. Slow session you have to join the regular batch only. Okay. 4 days we have to cover. Already you have cracked your exam. Already. Okay. You have recorded session also. You have to see. Slow session is not possible to finish if I go very slowly. You have to be very fast, active, because we are going to select only students those who crack the mains. None of the students outside they won't come for the class. Okay, we'll shortlist the candidate. Only those who are writing the exam. Chumma varla attend pannalam, it's not possible from tomorrow. Okay. This PDF won't be available. Okay, only those who are joining the session it will be available. Okay. Fine, no confusion. Sarita, have we cleared the prelims? 22 to 26 is bicarbonates. 35 to 45 your CO2. What is the confusion there? If you study more and more, you get confused in the basic. 22 to 26 bicarbonates is normal value, and you have in the question both the values are now. What was the question in ABG? Okay. No, see, Tamil தான் சொல்ற ESI prepare பண்றோம். தயவு செய்து இந்த செஷன்லாம் we eliminate. You don't want to join this session. Okay, இது ஒரு 10 நாள் செஷன் and then all will be going. சும்மா உட்கார்ந்து ESI படிக்கிறவங்க போய் படிங்க. நிறைய இருக்கு ESI ல படிக்க. இது வந்து ஸ்பெஷலி நார்சல் செஷன். ESI ல இந்த பேட்டர்ன்லாம் வராது. ஓகே, unnecessarily don't think you can study ESI pattern. காசு கம்மியா இருக்கு படிக்கலாம், ஒரு யூஸும் கிடையாது. ஓகே, you go and study the ESI classes going. You go and study that. Okay, this is only for AIIMS. ESI ஜூலை எக்ஸாம் 7. இப்ப படிச்சாலும் நீங்க மறந்து போறீங்க. இன்னொரு 3 மாசத்துல படிப்பீங்களா நீங்க? அந்த 3 months. Bicarbonation PCO2 normal 150. Irma, what was the question? Let me answer. இந்த prelims anion gap question கொடுத்திருந்தாங்களா? Hyponatremia sign muscle weakness, not a thirst. Hyponatremia sign தான் thirst. எப்படிமா thirst வரும்? Hyponatremia ஆப்ஷன்ல 4 ஆப்ஷன்ல thirst வராது. ஓகே, ABG 7.8. ஓகே, ஒரு நிமிஷம், 1 minute. Give the ABG question. ABG 7. PCO2 normal values, chloride and value given. Yes, calculate the anion gap, go for metabolic acidosis. பரவாயில்ல, இதெல்லாம் சொல்லி கொடுத்தேன்ல. I given already anion gap calculation, no? Yes, we have to calculate. Oh, எனக்கே தெரியாது. I have not this question came. பாத்தீங்களா? Already I taught you this anion gap to calculate. The question came. எத்தனை பேர் அட்டெண்ட் பண்ணிருப்பாங்க அவுட் சைடர்? No one will attend. Okay, sodium minus chloride plus bicarbonates, and that is okay, chloride கொடுத்தா bicarbonates, so you have to calculate sodium minus chloride plus bicarbonates. That is metabolic acidosis. Okay, mostly answer will be metabolic acidosis. எத்தனை டைம் இந்த டீச் பண்ணிருக்க அந்த ABG செஷன்ல? ஓகே, I don't know people attended or not. நான் சொல்ற செஷனை கவனிக்கிறதே கிடையாது மோஸ்ட்லி. இது படிங்க 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 படிங்கன்னு if I say also people won't listen. Anion gap வரைக்கும் question வந்துச்சுன்னா is very good advanced level. Okay, then I have to prepare osmolar gap and further deep only. I was waiting with this anion gap for last 4 years. இப்போதான் கேட்டிருக்காங்க. 2018ல இருந்து டீச் பண்ணிருக்கோம் anion gap. Now only first time it came. Okay, good. Okay, anyway, we'll go for further new questions. Let us see how I can work out for you people. Okay, so yes, thirst is for hyponatremia. Hyponatremia weakness. எங்க ஆப்ஷன் என்ன weakness தான், musculoskeletal weakness will be there. Okay, hyponatremia causes dehydration. Dehydration thirst இருக்கும். நிறைய பேர் thirst மார்க் பண்ணிட்டு வந்திருக்கீங்க. ஓகே, இதெல்லாம் see the slide. Who all studied? Anyway, you are in the rank. So don't worry. So you are going to prepare in the upcoming exam. So don't worry, follow my instruction and follow me, and maximum we'll cover everything in proper schedule. Okay, yeah, okay. Mostly I know that I checked. After checking only, I also feel 60 questions, 65 questions teach பண்ணிருக்கு. ஒழுங்கா படிச்சிருந்தீங்கன்னா ஸ்லைட ஒழுங்கா படிச்சவங்க எல்லாமே கிளியரா வந்து 65 கொஸ்டின் எழுதிருக்கலாம். அவுட் சைட் those who are sitting கிளியர் பண்ணாம வெரி சிம்பிள் கொஸ்டின் 65 கொஸ்டின்ஸ். அதான் சொல்றேன், people they won't listen. They are studying here and there on the book, in the book படிச்சு கன்ஃபியூஸ். ஸ்லைடு கண்டென்ட் படிச்சாவே ஒழுங்கா பாஸ் ஆகலாம். Content I given all the content clearly. Everything is there. After checking only we come to know 65 questions are there in the slide itself, fundamental slides and question series. ETD plaster, எனக்கு தெரியும் அந்த questions plasters. Generally I said that question also came. Okay, post operative position is by supine only. Okay, okay, anyway we'll be studying. Okay, so let us see, tomorrow we'll start the session, no issue. Okay, so let us see. Thank you all. So உங்களுக்கு வந்த கொஸ்டின்ஸா we have cleared ESI session. இப்போ எந்த லாங்குவேஜ் சொல்லணும்? ESI எல்லாம் ஜூலை தான் ஸ்டார்ட் ஆகும், ஜூன் தான் ஸ்டார்ட் ஆகும். ஆல்ரெடி one session is going ESI. Crash course always we have to come before 20 days before the exam, not before itself. Crash course நாவே எக்ஸாம் முன்னாடி வரதான் crash course. 3 மாசம் முன்னாடிலாம் crash course எடுக்க முடியாது. ஓகே, crash courseக்கு உங்களுக்கு மீனிங்கே தெரியல. crash course இப்பயே ஜாயின் பண்ணி படிக்கிறது கிடையாது. crash course பாதி கன்ஃபியூஸ் ஆடுவீங்க. ஓகே, you will get confused. Okay, fine. So thank you all.